Good evening, ladies and gentlemen, and welcome to this webinar. We will give 3 minutes to other people to keep joining in, and then we shall start by exactly 8:05 p.m. So let's give 3 minutes for other persons to join, and then we'll start at 8:05. All right. Good evening once again, ladies and gentlemen, and welcome to this wonderful webinar on focus. My name is Otiende Obonyo. I am a distinguished general and cardiac sonographer with over 10 years of practical and specific experience. And I'm privileged on this webinar to have very wonderful persons, very impressive people who will be talking to us about POCUS. And what we are talking about specifically is the power of obstetrical POCUS for every healthcare professional. POCUS, as we know, is point of care ultrasound. And this is a tool that, especially in maternal and child health, can actually go a very long distance in helping mitigate so many unwanted outcomes that normally are easily detectable by ultrasound. And so, because it is not practical to have very many sonographers or radiologists in various stations or various institutions spread out in resource-limited setups, POCUS becomes an integral part that can actually mitigate some of these things. It can actually come in the middle of avoiding the necessity of delaying either diagnosis or having to travel long distances to look for this service so that you can get to start care for the person that you are actually seeing. I'm privileged to have Dr. J.M. Nondi. For those of you who do not know Dr. Nondi, I'm going to read just a small profile about him so that we can be able to know who he is, but he will talk about himself later when he is actually introducing the other speakers. Dr. Nondi is an obstetrics and gynecology practitioner with over 15 years of experience in sexual and reproductive health. He is the founder and proprietor of Nectar Gynecology and Fertility Center. This is in Nakuru. This center is dedicated to offering affordable, customized, and client-centered care. He holds a master's degree from the University of Nairobi in obstetrics and gynecology. And he also has a bachelor's degree in medicine and surgery from the University of Moi, all in Kenya. Dr. Nondi is a member of the Kenya Medical Association, KMA. He's also a member of the Kenya Obstetrician and Gynecologists Society. He is passionate about teaching and medical research. He currently lectures at the Department of Obstetrics and Gynecology at Egerton University's Faculty of Health Sciences. He is a prolific researcher with many publications to his name and relevant trainings and certifications as well to complement his academic achievements. He frequently organizes various free medical camps and health talks in various educational as well as other institutions within the country of Kenya. And he trains medical professionals, legal professionals, and law enforcement officers on forensic management of gender and sexual-based violence in Kenya. So without any further ado, I would like to welcome Dr. Nondi to say hi. And Dr. Nondi has the privilege to actually introduce to us the next speaker who will introduce the next speakers. Karibu sana, Dr. Nondi.
Thank you very much. Thank you, Mr. Obonyo. This is indeed a very interesting opportunity to meet and share and discuss matters concerning maternal health. And I want to thank you very much for that kind introduction. I want to jump straight to introduce our main speaker. And we are privileged this evening to host this talk with our main speaker coming in as Dr. Joseph Williamson. This webinar has been made possible by collaboration between Nectar Gyne and Fertility Center, where I operate from, as well as the COGS, that is Kenya Obstetrics Gynecology Society South Rift branch. And we are very privileged to have Joseph E. Williamson, who is our main speaker. Now, Joseph Williamson has been the keynote presenter and consultant for international health systems, such as Cayman Island Health Authority, Barbados Palliative Care Association, Jamaica West Indies, Mandeville Regional Hospital Systems, Pinnacle Health Systems of the USA, and the Nigeria Association for Infertility and Reproductive Health. He has served as Africa Clinical Consultant for Intelios Group, the medical accreditation body that usually oversees the practice of POCUS ultrasound in the USA. He's advocated for the validation of the imaging skills through certification in such forums. He's a healthcare quality consultant for the International Finance Corporation in Africa, which is the private arm of the World Bank. We call it IFC. His expertise is in implementing strategies to help organizations attain high patient care quality, as well as good healthcare employee engagement. He has over 35 years of seasoned clinical experience, and he has become synonymous with innovation and excellence in healthcare consulting, as well as education and training across the globe. And he is an alumnus of prestigious institutions and has completed fellowship in maternal-fetal medicine. Joseph Williamson's journey in the world of medicine actually began in the USA, where he discovered a passion for diagnostic medicine. He has earned a medical degree in fetal cardiology from Sanford Brown University, and embarked on a path that will lead him to a thriving clinical specialist and fellowship in diagnostic fetal-maternal imaging and medical sonology. At the heart of Joseph Williamson's philosophy is a dedication to transformative programs in diagnosis and management of maternal fetal health issues. And this actually aligns very neatly with his forte in diagnostic medical imaging, and he believes in the ethos of patient-centered care. Among his achievements as a clinical specialist are quite a number of them. His career is highlighted by his significant contribution to perinatology, high-risk obstetrics, and diagnostic imaging, which has led, which he has led with visionary strategy. His focus is particularly valued by hospital groups in Africa and the Caribbean, where he meticulously evaluates clinical protocols and paves the way for enhancement of medical educational frameworks. With this rich introduction and resume, we are privileged to have Dr. Joseph E. Williamson as our key presenter this evening, and I want us to all welcome Dr. Joseph E. Williamson. Thank you, Karibu Williamson.
Thank you so much, Dr. Nandi. I hope everyone can hear me. And it is, it's an absolute pleasure to present to you this evening. I think this subject of point of care ultrasound has been long spoken about, but just recently have we actually started to do something about it when it comes to how we react in Africa to obstetric care. And fortunately, it is not just pointed at obstetric care, although that is our focus tonight. We find that obstetric medicine heads it because we know that in Africa, for instance, that maternal care is key to community. If moms do not have healthy babies, then communities suffer. And if communities suffer, then infrastructure suffers. So we want to figure out, and Dr. Nandi, I appreciate you and the introduction, but one of the things that I appreciate more about Dr. Nandi is he actually is at the forefront of things that we call all things maternal care. And so doctors like this that actually advocate for point of care ultrasound in obstetric medicine are the types of doctors that I think are pushing the healthcare infrastructure in Africa to be stronger. So the question is, how do we transform healthcare with point of care ultrasound? We have to explore the urgent need for point of care ultrasound training in obstetrics, in cardiology, in trauma medicine. But as we look at obstetrics, how is it strengthening the healthcare system? And it's simple, actually. In my experience in obstetrics, you strengthen the healthcare system and you direct the most impact at the thing that creates the most impact. And in Africa, it is maternal care. We have a lot of maternal mortalities in Africa based on the fact that women cannot obtain the proper care that they need to carry them through the rest of the pregnancy. When I was practicing in the United States, it was very simple because every maternal care center had 10 or 11 ultrasonographers that were very specialized in high-risk obstetric ultrasound. So when I ran centers in the United States, I almost took it for granted that I would always have sonographers and I would always have the support. Sonographers which I trained and sonographers which I inherited based on the fact that some of my colleagues had trained these sonographers and they had gone to school to become specialized. However, when I transitioned to Africa, I found the landscape very different. Sonographers in Africa are at a very, very high premium. And it means that there are a very few sonographers when you compare it to what is offered in Canada, what's offered in Europe, what's offered in the United States, and what's offered in Australia. So then how do we now strengthen a healthcare system that is missing the sonographers that we need? And it's very simple. We use point of care ultrasound and we arm medical practitioners that are non-imaging medical practitioners to actually do point of care ultrasound. What do we mean by point of care ultrasound? It's very simple. Point of care ultrasound is synonymous to when I would use a stethoscope to listen to a patient's heart. Because I'm using a stethoscope does not mean I'm a cardiologist. It means that I have been given the task of screening out these patients that need to go to cardiology, right? So as a point of care practitioner, whether you are a nurse midwife, or you're a medical officer, whether you're an obstetrician, your job is not to become a sonographer. Your job is screening out the amount of patients that need to go to sonography, that need to go to radiology, that need to go to a doctor like Dr. Nandi, that needs to go to a high-risk obstetrician. And so then we're only teaching a few things when it comes to point of care ultrasound in obstetrics. Let's take a closer look. the impact of point-of-care ultrasound in obstetrics has long been documented. There's a lot of data. We know that, for instance, in South Africa, where I happen to live and I am based, the majority of patients, and we would say a good 78% of patients, do not go to obstetricians when they're pregnant. They go to midwives. So the only time they find themselves, especially in the rural area, in obstetric practice, is when that midwife has said to that patient, you know what? This is something that we cannot manage here. We must send you to the next level, which is your obstetrician or your radiologist, right? So these midwives now are solely responsible for guiding these patients to the next referral transfer. So in South Africa, we've had the midwives form strong referral pathways with the obstetricians and with the radiologists. So what is the next step? The next step is now teaching these midwives how to do point-of-care ultrasound. Why? Because point-of-care ultrasound for African hospital strengthens the primary healthcare system at the maternal level, right? One, it improves diagnostic accuracy. If 78% of pregnant patients are not going to the obstetric doctor, the gynecological specialist, or the radiologist, where do they end up when there's an abnormality? If that mother has a complete placenta previa, if she has a placenta accretion, if she has the hint of an ectopic pregnancy, if she has oligohydramnios or polyhydramnios or anhydramnios, where do they go? How is that diagnosed if they're not going to the radiologist or an obstetrician? And therein, we have the beginnings of our increased maternal mortality in Africa. Since we do not have the bounty of ultrasonographers that we find in Canada, Europe, and the United States and Australia, we then have to add training to the nurse midwives, to the clinical officers, to the general practitioner consultants, to the obstetrics that do not have specialized training. So it improves diagnostic accuracy at the primary healthcare level. Number two, it enhances patient outcomes, because if I can have my midwives diagnose a complete placenta previa, or even tell me that, you know what, doc, I don't understand what's going on here. This placenta does not look right. They may not be able to diagnose it, but guess what? They can tell that something is not right after we've trained them. Remember, we're not asking them to be sonographers. We're asking them to rule out those things that they think may need to go to the next referral pathway. By utilizing point-of-care ultrasound, healthcare providers can make timely decisions that lead to better treatment plan, ultimately improving patient health outcomes. And number three, it reduces healthcare costs. Implementing point-of-care ultrasound reduces the need for more expensive imaging modalities and minimize patient transfer, thereby lowering overall healthcare expenses. We find that when we arm practitioners, such as midwives, such as medical officers, with a handheld point-of-care ultrasound device that is 1/8 the cost of a full device that a radiologist will use, then it reduces the healthcare burden cost. Because guess what? If I have to go and do an intervention in someone that has a placenta previa, that is a much more expensive procedure than if I can deliver that patient by C-section, because I already know that they have a placenta previa, right? So it actually does reduce healthcare burden costs. So if we look at point of care in obstetrics, just an overview. Number one, point of care is a bedside ultrasound technique that allows immediate assessment of maternal and fetal conditions during pregnancy. It is a bedside ultrasound technique, which means it is synonymous to the glucometer I would use at the patient's bedside if I just wanted to get a brief snapshot of what was going on with their blood sugar that day. So it is not, if I draw from the example of the glucometer, I'm not sending that patient to a full laboratory to get a full CBC, a full white count, a full hemoglobin. I am just asking one question: what is the blood sugar doing right at that particular moment? Let us direct our attention to this. Point of care is not a complete ultrasound that my sonographers would be doing. It is an answer to a direct question. And it is only asking a few questions. Number one, is there enough amniotic fluid? Number two, what is the baby's presentation? What is the baby's presentation? Is it cephalic? Is it breech? Is it transverse? Is it oblique? Number three, does the baby have a heartbeat? And is that heartbeat within normal range? Is it bradycardic? Is it slow? Is it fast? Is it intermittent? Is it indicative of a heart block? What is that baby's heart rate? Number four, where is the placenta? Is it inferior? Is it anterior? Is it low-lying? Is it marginal? Is it accretia? What does that placenta look like? Those simple questions on top of maybe a biophysical profile is all that we're asking our midwives and our clinical officers to do. So therefore, they're not taking over the responsibility of a radiologist or an obstetric practitioner. They are simply creating a referral pathway to actually increase the business of the radiologist, because these patients would not normally be seen by radiology anyway. They would not normally end up at an obstetric doctor unless the midwives are referring this. Number two, enhanced diagnostic accuracy. Utilizing and training medical officers, clinical officers, midwives to do point of care ultrasound improves diagnostic accuracy for conditions such as ectopic pregnancy, placental abnormals, and in some cases, abnormal fetal growth restrictions. Number three, it helps us as practitioners make a timely decision, because the old premise, when I went to school, one of my mentors always said to me, the decision you make is only as good as the information that you receive before you make that decision. I'll repeat that. The decision you make is only as good as the information you obtain before you make that decision. So if we do not have the correct decision about patients, there's no way we can manage that patient 100%. And what is point of care ultrasound doing? It's adding more decision. It's allowing healthcare providers to respond quickly to emergencies and complications. And in medicine, time equals life. In medicine, time equals life. Number four, we get improved maternal health monitoring. Point of care ultrasound enables us to continuously monitor maternal health. It helps us to identify issues early on so that we can again create a better referral pathway when that patient has to be referred. It also encourages us to assess the fetal well-being. Fetal heart rate and movements can be evaluated in real time, ensuring that fetal health is optimal throughout the pregnancy or whenever we're seeing that patient. A lot of times these patients show up at the midwife office one time. And so we have one opportunity to make sure that their care is correct. And point of care ultrasound influences this. And also it reduces, in South Africa and in Kenya and in Africa, it reduces the need for transport. We have a lot of people in South Africa that live in rural areas that have to pick themselves up and drive kilometers to a hospital to get one ultrasound by an ultrasound sonographer that's already so crowded that she or he have to sometimes turn patients away or work a 12-hour shift just to be able to accommodate the patients. Can you imagine if we armed nurse practitioners, nurse midwives, medical officers that travel in the rural area with a handheld ultrasound, taught them how to use this, empowered them how to use this, and credentialed them with a global POCUS point of care ultrasound credentialing, the same that Europe or the United States is using, would that not change the way that medicine is practiced in maternal health in rural areas? And my answer would be yes. So in conclusion, let's do a call to action. What's the summary? We need to initiate training right away. This is not something we need to talk about. It's not something we need to debate. It's not something that we need to take to the president. We need to initiate training. And sometimes we find, especially when we did this in South Africa and when we did this in the Caribbean, that the private sector picked this up and ran with it. So then the government sector followed and collaborated. Sometimes the private sector has to start things. So this is not a subject that we should be debating on for another year before we initiate training in Meru, in Mombasa, in Nairobi County, right? We should be figuring out how we can initiate training now. And we have already done that in Nairobi. We're doing that in Meru. And we're now in talks with other counties to initiate this type of training by training sonographers to train, by training nurse midwives to train, by training obstetricians to train. Number two, let's lead the change by championing point of care ultrasound training for your particular healthcare staff. You position your country as a leader in innovative healthcare solutions. We have private hospitals, and I'll mention one. Royal Family Healthcare Clinic has been a leader and a game changer when it comes to training in point of care ultrasound. They have contracted to train not only in obstetrics, but in point of care obstetrics, point of care cardiology, point of care emergency and trauma medicine. And we have also clinicians that are looking at training in point of care HIV management. That is how far POCUS have gone. So my challenge to you is, where is your institution in point of care? Have you even began to speak about it? And if you're doing it, is it sustainable? Are you registering? Are you certifying your trainees? Number 3, invest in technology. We have gotten to the place now in Africa where we're far beyond donor funding. That has been proven to us in the last few months. We need to invest in our own healthcare technology and management. And if you're speaking about a point of care piece of equipment, you're talking about a minuscule cost, comparatively speaking, to what we spend to, let's say, go to a medical conference, or what we spend for expenditures and procurement in the rest of our hospital systems. So we need to invest in our technology. Ensure that your healthcare facilities are equipped with the latest POCUS technology. We have partnerships with a lot of OEMs in Africa. So this is not a problem. It's not for lack of procuring the equipment. It's a lack of, we need to take a look at this and make overall plans. This investment will enable your staff to provide enhanced diagnostic services, improving patient outcomes, and reducing the need for constant referral. And last, please foster community engagement. We are Africa. We are community. There is no competition. I had a conference once, and the doctors came up to me after the conference and they said, you know what, doc, the things that you're talking about, we can't institute, because if we institute them, the doctor next door might do it, and we're in competition. And I asked him, I said, why are you in competition for patients in the largest continent on the planet? Being in competition for patients in Africa is like being in competition for a drop of water in the ocean. It shouldn't happen. There's enough patients to go around. Can you imagine what would happen if we collaborate, if we cooperate, if we form private-public partnerships, if we try to, instead of fighting each other on this, if we try to work together, foster community engagement. So I'm going to stop my presentation there and turn it back over to our moderator. And I hope that you've gotten something out of this talk, out of this presentation, and we'll open it up for questions, but I'll turn it back to our moderator. Back to you.
Thank you very much, Dr. Joseph. That is indeed a very succinct presentation about POCUS. And I'm just imagining how much that everybody has already gathered. And just to bring the point home, let me give you a small story of a practical real-life situation that happened. A patient walks into a medical facility, a government medical facility, and she's having a headache. They look at the patient and look at her pressure and other vitals. They say they are stable and they are okay. So they tell the patient, you can go home and relax, and give the patient pain medication. The patient goes home, takes a break, but then now starts having abdominal pains. Goes back to the facility. They are told now, okay, let's do an ultrasound. The ultrasound is done, and then it is reported as normal. The patient is told, you're okay, you can go home, everything is okay, you'll be fine, take some pain medication, and you will be okay. And then the patient goes back. And then because of anxiety and also a bit of the symptoms that the patient is feeling, decides, let me not go back home, let me go and stay with my friend for a minute or so before I cool down and probably go home. And as she's staying with a friend and they're making stories and everything else, the headache worsens, the abdominal pain worsens, and then she starts bleeding. And as she's bleeding, she's rushed back to the hospital. And the person at the hospital now tells them, we have to go and see an OBGY. They go to the obstetrician, tries to do fetal heart monitoring, tries to scramble a team to do a scan, but the bleeding is too much. They decide to, try and go and see whatever is going on. So the person who is at the facility of the OBGY says, the heartbeat is there, it's non-reassuring, I'm not sure what is going on. So the OBGY says, okay, the best thing to do in this case, I'm suspecting the patient has a blood show, let's just go ahead and try to save the baby. They go in for an emergency CS, and unfortunately, they get a situation whereby it is a fresh stillbirth. And I'm just imagining that with what Dr. Joseph has just explained, if, for example, we armed the people at the very first point of care for this mother, they could have at least put a probe and looked at this mother and found something, at least something I know could have been given. Could be the heartbeat, could be blood flow in the brain, could be a collection behind the placenta. Something could have been found that could have necessitated, care for this mother, and probably this situation could have been mitigated. This is an example that I'm sure happens a lot of the time for very many people in resource-limited setups. And the way Dr. Williams has just put it, I cannot elaborate, emphasize, or put it any better. This is a technology that we should embrace, because the idea here is to ensure that we give the most optimal care, especially now in these cases, for mothers. I don't think any mother should carry a baby and lose that baby for whatever reason, especially if the reason could be detected and mitigated early. Thank you so much, Dr. Williams. And I'm
Dr.
going
Moses,
to
Dr. Moses, can I interject one thing before you move on, sir?
Sure.
I think we are very honored to have on our call, and I just saw him, the director of marketing for Mindray Africa. And I just wanted to give him a minute to tell what Mindray's opinion is on point of care ultrasound, because I think that it's very, very important to get the 2 minutes of the manufacturer that's actually one of the manufacturers that's actually trying to push this. Mr. Mamanti, are you there?
As Mr. Mamati speaks, I would like him to also specifically talk about the kind of solutions that are providing that could help in POCUS as Mindray.
Perfect.
Thank you, Tim. Thank you, Dr. Joseph, and thank you, Moses. This is a very enlightening forum, because POCUS is the new wave in ultrasound. It's like the new kid in the block. And I cannot overemphasize on what you've just mentioned, speaking the different spectrum of what POCUS can do. We shall get another day to discuss in detail, but Mindray primarily has got an array of equipments that covers the POCUS portfolio. But what resonates primarily with what you've done today is the handheld TE Air, which is the E5M. It's a fantastic handheld equipment, and I think in the next session, maybe we shall have a moment to discuss about it. But it's a fantastic handheld ultrasound that comes on with the board of a lot of measurements. It can do color Doppler, it can do pulse wave, it can do continuous wave, and all those are the things that have been described here. I know today's agenda was different, just to discuss about POCUS and its scope. So I'll not want to take a minute or more of the whole team. But yes, Mindray is a strong original equipment manufacturer producing handheld ultrasounds. And already we've got strong partnerships in Kenya, Uganda, Tanzania, Nigeria, Ethiopia, which we're already rolling out these platforms. In the near future, I'm sure we are having a partnership and collaboration, and we shall be sharing out trainings on the same. So unless there's something specific that Dr. Joseph, you wanted me to speak about, but I want to thank you for what you're doing, educating people, sharing knowledge, and just encouraging people to understand and appreciate the scope and strength of POCUS. Thank you.
Thank you very much, Anthony. Back to you, Mr. Moderator.
Thank you, Mr. Mamati. I'm privileged to have been a student of Mr. Mamati when I was doing my very first training after high school. That is a diploma in medical imaging sciences at the Kenya Medical Training College in Nairobi. Mr. Mamati, it's a pleasure to have you. Before I move on to the next
me look
speakers,
so old, Moses.
I'm sorry for that, but I'm giving you due respect, you know. But before you go, I'm sure this is a question that is going to come up. I would like you to specifically talk about the cost implications for these novel techniques and technologies and equipment that are being produced, because one of the things that happens is that the cost factor comes in when we are trying to implement such programs as POCUS. What is it that you guys are doing? What is the cost, and what are the solutions or options available in terms of financing?
Okay, that's a good question and a tricky one, because speaking about cost primarily sometimes scares people. But what we try to first speak about before even we speak about the cost of the equipment is the value that it comes. Look at a whole ultrasound being brought out into one handheld device and look at the scope of what it does. I know the cost varies from one place to another and there are payment terms to that, but it ranges something between 0.5 million in Kenya shillings to around 0.7, 0.6, depending on the configuration that you want. So for each configuration that you want, the scope changes a little bit, but it's something manageable. It's something within parameters that people can manage. And looking at the value and the scope that it brings with, then cost becomes very negligible. Keeping in mind that the cost of a probe and looking at this is a probe that does almost whole body function, the cost supersedes all the value. The value supersedes the cost. So I'll not put any figure, but at least I'll say if there are people who would want to know more about the cost, people who would want to know more about how they can get one, I'll put my details on the chat box, then we can catch up after this, or they can reach out to me, then we can discuss in detail. But giving out a figure primarily will not be a fair evaluation of the price indication.
Thank you, Mamati. Well understood.
There's a question that has just come on the chat box. How can an institution like Aga Khan collaborate with Mind specifically on POCUS? Aga Khan is one of our biggest supporters, and if it pleases you on your time, I can come and we visit and we look at which area of scope you'd like us to look into, be it trauma medicine, be it OBGYN, and we can see how we can partner and how we can support you. One of our biggest role is to provide the equipment and training, then you can have a chance to use it and experience it. We also have a demo one in Kenya, which we can bring to you for experience and just have a feel of it. So again, I'll pick your details from here, and I'll also share my number and email address so that people can pick it offline.
So I think he said Aga Khan in Tanzania. Anthony, is that because I think I see that on the chat? It's not the Aga Khan in Kenya; it's in Tanzania.
I'm seeing it is Abeid, Aga Khan University only. It didn't mention Tanzania, but Tanzania, we've got a strong linkage there. I can still link you up to my colleagues who are there who can support you. And still, I'll be very helpful. I'll be very willing much to support you even in Tanzania. So again, I'll just share my details so that you can reach out to me even offline. Thank you.
Thank you, Mr. Mamati. We'll be waiting for those contacts. And I think what I'm learning here is probably to have another sit like this one where we can simply talk about what you're representing, the people you're collaborating with, and what actually we can be able to do in terms of working together with Mindray. I want to move on kindly to contact has already been shared in the comment section. Feel free to look in there and get those contacts, and you can contact Mr. Mamati on that. In addition to this, ladies and gentlemen, feel free to ask whatever questions you have within the chat box. They will be addressed adequately. Before I move on to the next speakers, Dr. Nondi, I wanted to ask you to help us put into perspective whatever we are talking about, because I know the other speakers are going to talk about the other technical aspect, but in your experience as an OBGY, having practiced over 15 years, what are some conditions or obstetrical complications that you think can be detected or can be diagnosed, or you think that POCUS can actually help in detecting and helping to arrest the situation early enough?
Yeah, so thanks very much, Mr. Bonyo. We, in our daily practices, and I know a number of gynecologists here will agree with me, we come across issues like placenta accreta issues. We come across polyhydramnios, for example, oligohydramnios. We come across basically a lot of fetal issues that could easily be picked by someone with good, just basic knowledge on ultrasonography. And this can actually change a lot of things and the way we practice. Even just merely the way the fetus is lying in the uterus, sometimes it's not very clear from palpation. When you do Leopold's maneuvers, you don't get clear information about this, particularly when you're dealing with multiple gestation and so on. So I think these are some of the things that we come across on a daily basis. We get a lot of early pregnancy bleeding situations, the threatened miscarriages. You want to know whether we are dealing with a complete miscarriage here, or we're dealing with a threatened one, we're dealing with incomplete miscarriage and so on. So this then becomes very useful for someone who is actively practicing obstetrics. So there are quite a number of examples that we come across, but just to mention a few, we have the ones I've already talked about. We sometimes want to help mothers, and most of the time we do this, to decide on the mode of delivery. And here we want to help with estimation of fetal sizes. It becomes, of course, there's the physical way of doing it through tape measure and all that. But I think it would be nice to have knowledge on how to be able to even do fetal weight estimation for purposes of deciding the mode of delivery and so on. So we come across quite a number of this on a daily basis. And this is not only by obstetricians, you get midwives coming across all manner of situations, clinical officers, medical doctors and medical officers, and so on. So we get quite a number of these situations. One of the things that I wanted to also say at this point is that when this kind of awareness starts at the level of a medical student or a clinical student, then I think we will achieve a lot, and you'll realize that I had invited quite a number of my medical students in this forum so that they participate in this kind of webinar, because I think if I had been given a chance as a young medical student, for example, in POCUS, I think my practice would have been so rich in terms of experiences, having this kind of knowledge. So I believe this is very useful even to them. I think I stop there, Obonyo.
Thank you, Dr. Nondi. Thank you very much. My next question goes to Molly, who is our other speaker. I'll give her the pleasure of introducing herself, but after she introduces herself, I would like her to tell us what are the essential skills on a training perspective that a clinician should master when using POCUS. Molly. I think Molly is disposed, and I hope she'll come back to us. Dr. Williams, do you want to take that question? What are some of the essential skills that every clinician should master when using POCUS?
Thank you for that. I'm going to actually direct that question at our other trainer, sonographer, Shadrach, until Molly comes back online. Shadrach, are you in presence?
Hi, yes, I am. How are you doing?
Okay, I'm wonderful, sir. Can you introduce yourself as well as if you can attention to the question that Moses has just asked?
Yeah, hi everyone. My name is Onyango Shadrach. I am a sonographer based in Nairobi, Kenya. I majorly specialize in obs-gyn, abdomen, and emergency and trauma sonography. Just that's briefly. Now, moving on to the question that the moderator has asked, that the essential skills which a healthcare provider should be endowed with to effectively use this tool. Well, we do understand that as a non-radiology healthcare professional, you are not privy to the physics or the mechanisms of ultrasound, how ultrasound works. So we do not really want to give you all the physics for you to master and cram so that you it becomes so effective to you. We just want you to understand at the basic level how ultrasound works. We know it's through sonic waves, so we will want you to have the information of how waves are transformed into the image, and then the images are provided on your screen, so your handheld devices for you to interpret. So basically, number one, as a healthcare professional, non-radiology healthcare professional, basic ultrasound physics and instrumentation. That's basically understanding how ultrasound waves interact with the tissues and how to operate the ultrasound machine. Now, given that this is a handheld device like a tablet or a phone, you do not have access to all the knobs that a fully fledged ultrasound machine will be having. So there's limited knobs, but all of them are on screen. So by just understanding what does what to adjust your image to get a better image, in as much as you're using a very small handheld device, that will be nice for you. Also, the different transducer types and the applications. But in POCUS, unlike the general sonography, you do not have access to the different probes. So in ultrasound, we can have a probe for transvaginal examinations, a linear probe, and a curvilinear probe. In POCUS, all those are brought into one tiny probe, which does everything. So basically, how that works, what it contains, will be good for you to go. Also, you need to understand how image acquisition works and how to interpret. We know that for you to know the abnormal, you have to figure out what the normal is. So you will be presented with the case of a normal patient, a normal maybe 15-week pregnancy. How does it present? What are the things that you are likely going to see? And then from there, you can be introduced to how do the abnormal present. So if you're talking about, let's say, placenta previa, in a normal case, we do not expect the placenta to obscure the cervix. In placenta previa, we will expect that it's either low-lying or grade 1 to grade 4, depending on what stage of previa it is. So we'll want you to understand, how does a normal placenta present? Where are its location? Is it anterior? Is it fundal? Is it posterior, or is it posterior and low-lying? And then you can move on to understanding, how do the abnormal types present? And then from there, you can make your judgment whether to refer it to another doctor or proceed with management or give guidelines to the patient, however best your hospital guidelines suggest. Thirdly, this, Dr. Nondi, you have been talking about that it will be nice for you to know gestational age assessment. Now, an accurate measurement of fetal biometry changes over time. We do understand that sonography is subjective. So let's say you're given a curve to measure all the areas of the curve. Between me and Dr. Williamson and Dr. Nondi, if you're given the same curve to measure, we are certain not to have the same measurement. That is how ultrasound works. But we do expect, contrarily, that the values that we are going to get will be within a certain limit. And by having those limits, then the machine will do its calculations, then give you a gestational age. Now you can combine that with the Barcelona chart that the OBS and GYNs use, all the tape measurements, and then you can come to a conclusion on what is the approximate age based on your on the tape measure or physical manual measurements, and that which has have been provided by the ultrasound machine. Additionally, fetal well-being assessment. Now, when we talk about fetal well-being assessment, this becomes rather complicated. But in POCUS, we do not want to delve so deep into understanding what fetal well-being assessment, because if I take a midwife to do this fetal well-being assessment, I do not expect that her level will be the same as that of a fully trained sonographer to establish what fetal well-being will be. So for the non-clinical, non-radiological professionals, when we talk about fetal well-being assessments, we'll expect you to evaluate the fetal heart rate, the amniotic fluid volume, fetal movements. Now, we do realize that most of the times, expectant mothers will come to the clinic and they will complain of reduced or absent fetal movement. Now, that becomes challenging for them because it's really costly if they have to be coming to your office every other time and being sent to the radiology to do the same exam. In Nairobi here, where I work, the cheapest scan will be 4,000. That's about $30 or 35 thereabout. When you're using a POCUS instrument or tool, that amount can be really reduced to the bare minimum, about 800 to 1,000 shillings, just by you doing it and observing for a few minutes if you see any kicks or movements or opening and closing of the mouth. Then you'll have established cause already, rather than having to send the mother to the radiology for her to queue up and pay a lot of money for something which could have established by yourself and cheaply so. We've talked about placental assessment. Some things we really will not be happy if, not happy rather, but it will not be expected of other clinicians to know how to detect there's common obstetric complications such as like ectopic pregnancies or issues with multiple gestations, but we really will not want you to go highly into determining if the cerebellum is there or measurements of the ventricles in the brain. So just understanding the common conditions that patients present with PV bleeding or leaked fluid. So you measure whether it's enough or not. What's the cause of PV bleeding? Is the pregnancy intrauterine or extrauterine? Then from that case, if you cannot establish the exact position of the extrauterine gestation, then you can refer it higher to another trainer, another sonographer to evaluate further. Then lastly, I think documentation and reporting will be very essential for the midwife, especially to just record accurately interpret exactly what they saw. And by taking very few snapshots, which can be stored in the image, then you'll have a better understanding when you have to present it to another doctor for as a referral or just further monitoring and evaluation. I think that will be it. Joe.
Well, thank you.
Thank you very much. Thank you very much, Doc. And the next question that I wanted to ask was to Nondi. And I wanted to ask Dr. Nondi from an OBGY perspective. What does fetal distress mean? And what do you expect the sonographer to report to you when you're sending this patient for an ultrasound scan? Or rather, if it is at a POCUS level, what do you expect to be the information that is going to come from the person who is at least attending to this patient? Or what is the perspective? What is the OBGYN perspective? And back to Shadrach, in the same vein as this question after Dr. Nondi, I wanted you to tell us what are some of the limitations of POCUS that have come up since this is something that you have been doing for some time. Dr. Nondi.
Yes, so thank you, Wanyo. Now for fetal distress, basically, we tend to go gravitate towards the term known as non-reassuring fetal status, because that then encompasses quite a number of parameters we look at when you're looking at a baby who is not doing well in terms of their well-being. One of the things that is strikingly important for us is the fetal heart and how it varies. We have, the way the fetal heart will fluctuate from time to time, which is, can happen within acceptable limits. But then when it goes to those very bad either accelerations or decelerations, then that tells us that there's something happening with this fetus. So from the ultrasound point of view, that fetal heart rate to us and the regularity of it then matters to us a lot as gynecologists or maternal health specialists. It then is important for us to marry this with other aspects of biophysical profile. which then gives us a complete picture of how well this baby is doing. A distressed baby, for example, will score poorly in terms of biophysical profile, as well as, of course, other aspects we look at. But to answer your questions more directly, we measure around the fetal heart and the way it is going to fluctuate, or the way it is going to be reported, so that we are able to be able to know whether we are having a baby that is not in a good position in terms of basically a baby that is distressed, the fetal distress, just to answer you briefly.
Thank you very much. Shadrach, what are some of the pitfalls that you think clinicians should be aware about when they are dealing with POCUS?
Shadrach, before you answer, can we, since Molly's internet is intermittent and she's back, can we direct that question to Molly?
Okay.
Molly?
Good evening. Thank you for the opportunity. Thank you, Mr. Obonyo, and thanks for your patience. To answer your question, some of the limitations to POCUS, we have several limitations to POCUS, and some of the limitations to POCUS come about due to lack of skilled technicians and nurses or clinicians in this capacity when you're looking at this space being handled by the clinicians and nurses. The challenging areas that we have are currently that most of our clinicians and nurses are not really skilled to perform POCUS. Another challenge is the misinterpretation of ultrasound. Ultrasound sometimes seems quite easy, but again, it's confusing. And so poor misinterpretation of images and what one is doing can always bring about the limitations or the pitfalls to it, hence making it not important for that particular issue or case that it was supposed to handle. Another limitation is that as of now, we still don't have policies. Of course, a good example is in our country, the government is still trying to work on the policies and the way forward and all that. So we do not have the policies set to guide whoever is supposed to do and take over POCUS, be it the nurses, be it the clinicians, and depending on the area of expertise. In this particular point, you're looking at obstetrics. And so we really measure it on the midwives. So it becomes a challenge when we do not have policies that guide them. And therefore, people miss out on the scope of what they're really supposed to handle. In such instances, then somebody will want to go above and beyond their area of specialization or expertise, be it that they're trained under POCUS. It is always important that they stick to what they are required to give. Just like Shadrach had mentioned a few minutes ago, we wouldn't expect that the nurse will want to do the complete comprehensive ultrasound. But having been in the field and seen and also trained in some places, you realize that they want to get more, which is a good thing. It's always good to want to have more knowledge, but it's very important to stick to your scope to avoid going beyond what your scope requires you. Because when you go beyond what your scope requires you, you possibly will deny this client the right to quality healthcare. Yet POCUS was supposed to take us to the next level and game change the space where we do not have ultrasound units or we do not have sonographers in place. So sticking to your area based on what the policy guidelines are saying is quite important. Another limitation is, of course, availability of the machines or the probes and the screens that are supposed to be used for these services to be offered. That becomes a challenge. Then, of course, we are looking at, majorly we'd want to put it in the scope of looking at it from a point of either we are dealing with it from the low settlement areas, and the other issue will be limited of course, limited equipment and time constraint in terms of, say, the number of patients you want to attend to. We all can attest, especially the sonographers in the house, that sometimes it's quite heavy.
It's quite heavy
in the
in the department.
And so
the
nurses
have so much,
and they also
and they
have
also have the
focus
add to.
it becomes
It becomes a
challenge.
challenge.
Such are the limitations that come about. But they are all things that can be managed and worked upon. For as long as we follow the right channels, right protocols, everyone does what they're supposed to do, and the podcast space is standardized so that we all know what we are supposed to give. Of course, then other things will be the technical limitations where image quality is not what you expect. Of course, that is a big challenge because having done ultrasound over years, you have understood how to optimize your image to the best level of ability that you can to give quality diagnosis. So as time comes up and there are people coming in to practice POCAS, it needs a lot of practice because ultrasound is real time and we all need to practice. The more you practice, the more you become better at it. So once there is good practice, good regulation and availability of the machines and standardization of the policies and protocols, then we limit our limitations to achieving the very best through POCAS.
Thank you very much, Molly. Thank you very, very, very much. I still have another question directed to you, but before I do that, I would like to direct the following question to the president of the Society of Radiographers, the Kenyan chapter. Mr. Jevas Kenyanya has just joined us. Mr. Jevas, karibu sana. And my question to you is, there has been this issue where radiologists feel the sonographers are doing what they're not supposed to do, and now sonographers feel the people who are trained on POCAS are doing what sonographers should do. From a policy perspective, what is SOC doing in regard to being able to distinguish these various separate roles? Also to encourage POCAS, because we know that people mashinani are really, really suffering and they need this service. From a policy perspective, is there anything that is being done to address this? And then to Molly, you've mentioned about image quality. So how do you address the variability in image quality pertaining to various diagnoses? And lastly, to Dr. Joseph Williams, what is the role of AI in POCAS? And are there imaging or new technologies that are emerging that are going to help this particular aspect of care to the patient sort of move faster or become better in the future? Mr. Jevas. Jevas Kenyanya, President
Yes,
SOC,
yes.
are you with us?
Yes, yes. You can hear me?
Loud and clear.
Thank you, Mr. Moses Obonyo. I actually joined from the very first minute the webinar started, so I've been around. One, I want to appreciate the organizers for this webinar because it is a forum where we are doing empowerment and we are doing benchmarking and skills exchange amongst ourselves. My name is Jeffers Kenyanya. I'm the president, currently the president for the Society of Radiography in Kenya, under which the practitioners of ultrasound sonographers belong. I must say that from the policy perspective, to answer your question, it is true that a point of care ultrasound is something that we cannot run away. And it's not only an issue that is localized, but it's a global issue where now the world has recognized, the practitioners have recognized the role of ultrasound, and especially in quality management of our patients. So it is actually an opportunity where we have agreed to task share. where we give a limited task sharing skills. In the principle of task sharing, we give skills to our midwives, our obstetricians, and the rest of the cadres that work within the reproductive health space, ultrasound skills that can actually enable them to be able to attend to their patients and using ultrasound to be able to make decisions for quick intervention or even referral. So we are recognized as sonographers that point of care ultrasound skills given to a midwife is actually going to enhance the quality of care to our mothers, our sisters, our wives at that point of care. And in any case, increase what we could actually call as clean referrals to sonographers for better diagnosis if required. Otherwise, then it would actually be also clean referral to our obstetricians for what we could call interventions, early interventions, if there was a need for that. So the country has come to that realization, the Society of Radiography in Kenya, together with the Kenya Association of Radiologists, and we have talked with the ministry, and the ministry agreed to this, and we are developing what we called point of care guidelines and policy. The policy will be anchored under the Division of Reproductive Health in the Ministry of Health in Kenya. And the guidelines have actually been developed so far. And I am aware, and I'm actually part of the team that is now working on what we call as training manual. And in those policies, we are actually specifying what we call the scope of practice for the OPOCAS, where we are only talking about 5 indicators, and those 5 indicators were extremely well elaborated by my friend Joseph Williamson, where we are only looking at POCAS to look for the placenta position, POCAS to look for the liquor, amount of liquor, POCAS to look at the presentation of the fetus, number of fetuses, viability, and age estimation by ultrasound. And we felt that those are the critical areas that usually would actually be of value to a midwife at that point of care to make key decisions, either to refer or to refer for diagnostic scan or to the gynecologist for an intervention if necessary. So the training manual, the curriculum is being piloted on behalf of the ministry. And once the curriculum has been piloted, which actually also brings an element of regulation. How is this practice of OPOCAS going to be regulated? What kind of equipment, the specs, that kind of equipment that are going to be used in OPOCAS. And together all of us have agreed that OPOCAS is not being launched because of lack of sonographers, because as the president of the Society of Radiography in Kenya, I'm aware that we have sonographers who are out here and they need jobs, but we are doing OPOCAS as a limited task sharing for purposes of managing patients at their point of care and get clean referrals to radiology and have interventions that could otherwise be very fit to our mothers and children. So that's what is happening. And I believe that in a matter of a few weeks from now, the ministry should be able to launch the curriculum together with the guidelines that have been developed over a period of about a year or so from the time this discussion started. I'm not sure whether I've answered, but I think I'm here to respond to any other further questions, Mr. Moses.
Thank you very much. You have answered adequately. Dr. Joseph Williamson and Molly Alwuch, you can take a minute, just a minute, because we have got so many other questions that I want you to answer. Molly?
Oh, thank you so much. To say a word or two about the variability in relation to image quality. This comes about, of course, there's a level of expertise that you gain throughout in the field as you continue practicing ultrasound. But just like I had mentioned before, when we have standardization, and in standardization, we have policies and guidelines, and what our president has just said, a curriculum that guides what the persons practicing POCUS are supposed to have, the knowledge they're supposed to have. Image quality will come about when you have gone through a proper curriculum. And in the curriculum, I want to believe that physics is part of the curriculum. So with physics as part of the curriculum, it's a very basic component, but it's very necessary to understand how image is produced, to understand how images are well optimized to give you quality, regardless of the kind of machine or the type of machine you're using. Sometimes we want to say that the machine is too old, but when you're able to optimize your machines using things like gains and focus, that's a whole physics in there, then you're able to get good images. And that is what brings about the variability of image quality. And just also understanding the bits of anatomy that you need to understand so that you know what you're looking for. You know where to find it or how to find it. So those are the things that might bring about the variability in terms of image quality and what you're getting and what someone else is getting. So yeah, thank you.
Thank you very much, Dr. Williams.
Yes, so really briefly, the question that you asked me, Mr. Moderator, was AI in POCUS, will it become better? What do I see? Well, for instance, we are now involved with creating AI algorithms for every imaging modality, from CAT scan, MRI, and ultrasound is no different. I think I'm going to speak that I'm probably the oldest person on this line. I remember doing ultrasound when we didn't even know what Doppler was. There was no Doppler on the ultrasound machine. Everything was a static, really black and white image. What we see now is we're working with manufacturers to in the future, automate image interpretation. This does not mean the AI is going to interpret and tell us when a baby has trisomy or when a baby is placenta previa or something like that. It means that basically what the AI is going to do is guide the user in how they are doing this thing and if they are at the right level. For instance, if we're measuring a biparietal diameter, are we at the right level of the thalami? Are we seeing ventricles? Because if we're seeing ventricles, it means we're too low in the too high in the baby's head. If we're seeing cerebellum, we're too low. The AI will be able to know that we're in the right position to measure and therefore assign it a measurement. Number two, training and education. The AI will also be able to institute. We have right now in South Africa where we're using an AI to actually train our nurses to do cervical measurements and things like that, because the AI then knows that given the thousands of cervical measurement it has looked at, this one that this nurse is doing, the calipers need to be more in the internal os or more at the internal os, and it guides her to do that. We also have an AI now that knows who is scanning. In other words, if let's say one of the sonographers that are trained is scanning, it actually knows the difference in scanning technique between a trained person and a non-trained person. So it is trained now to actually clue the non-trained person, just as like the nurse or the clinician that is not trained as a sonographer, as to where they need to be to take certain pictures. And lastly, remote calculations in telemedicine. We see that the AIs now are being trained with an algorithm that if someone, for instance, Moses is doing an ultrasound in Jamaica and he needs me to take a look at it, the AI will actually start sending me images that it needs me to take a look at because it's not satisfied with the results that's coming out of Moses, as long as he authorizes that. And then workflow. It will know if I'm doing a fetus and I've programmed that workflow to go first do the dates, then do the fluid, then do this, then do that. It will walk the nurse through that workflows that she keeps on task, because sometimes scanning a baby can be very confusing. I mean, I've been doing it for like almost 40 years and I still get confused when I go in there, especially with multiple gestations, oligohydramnios and things like that. So simple answer to your question, AI is necessary. We see it in every single image and modality. Ultrasound is a little bit special because ultrasound is user dependent, whereas CAT scan, MRI, gamma is not as user dependent. Those are machine dependent. But all I see is AI getting better and better and better when it comes to ultrasound. So absolutely, and Anthony, I think Mamadi is still on the call, actually has programs now within the TE-Air, which is MindRay's ultrasound machine, that are AI enabled. So, Mr. Moderator, definitely AI is necessary and it will need to be learned by our practitioners in the future. Thank you.
Thank you very much. My next question is to Dr. Nondi. From an obstetrician's perspective, what constitutes an adequate, thorough ultrasound report? What would you expect from a person doing POCUS, and what would you expect from a person doing sonography?
Thank you. That is a very interesting one, but this is how I would look at it. Of course, a sonographer giving you a full report about a patient, you would want to look at a number of things. We are guided by the gestation that the patient is in. The trimester, whether in the first trimester, second trimester, and third trimester. Of course, in the first trimester, our focus usually is on the viability of the pregnancy, and particularly if we can clearly identify the fetal pulse and the fetal heart. That to us as healthcare practitioners, especially obstetricians, is usually very important because we want to make a decision about whether this is a pregnancy that is viable or not. Then we go to the second trimester and you are focusing mainly on the anomaly scan. You're actually very much interested in how the fetus has formed, and we would then appreciate a scan report that fully looks at all the systems and then gives us a report that is complete in terms of all the systems, so that we know that this is a pregnancy that requires further interventions, or we would need to proceed with it the way it is. Then we move to the third trimester, and you may have to do multiple ultrasounds at this point, because you want to continuously know how the baby is doing. The biophysical profiles becomes very important. One other thing that becomes very important for us at this point is the resistive indices of both the umbilical vessels as well as the mid-cerebral arteries, so that, again, you know whether we are having a good development, a good blood flow to the fetus, and so on. You'll also, of course, want a report that puts and gives you details on the placentation. You want the estimated fetal weights and biophysical profile and all that. So for a full and complete ultrasound report, then such kind of considerations will have to be put in place. But I think for POCUS, and here I stand to be corrected by the other presenters, we basically want to pick up or pick out some very key things that then could inform our next action and referrals. Particularly, something like the fetal heart is one key component that anyone doing POCUS should be able to pick up. Placentation, I think, and as the issues do with the fluid, amniotic fluids, so I would summarize this by saying that, of course, we have limited areas to focus on POCUS, but for a complete ultrasound scan, then the areas I've mentioned then become very important for us. Maybe one of the presenters, particularly the sonographers and Mr. Williamson, Dr. Williamson, can tell us more about what then to focus on in POCUS. Thank you.
Thank you very much, Dr. Nondi. I think each presenter will have a chance to add on to that. You guys have got a minute. I want to pose the next question to Shadrach. And Shadrach, my question is, how do you recommend that institutions structure POCUS training programs? I know there is what is currently present, that is what we are doing, that is what QualCare is doing, but what would be your advice based on experience to institutions on how to integrate or to structure integration of POCUS training?
Well, Thank you. I think when we talk about focus, we should first consider it as an extension of the physical exam and not necessarily a part of the radiology service in itself. So when you're going to structure the integration into a hospital system in a way, then it should come from a point of the first point the patient comes into the doctor's office. Then therefore, we can think about having a multidisciplinary team that when you form a committee of physicians, sonographers, nurses, and administrators with expertise in POCUS, who will then curate how POCUS will be used in their hospital. Additionally, I believe we should be having clear policies and protocols of how and when we are going to use POCUS in patient management or assessment by developing standardized protocols for POCUS examinations. In this case, we are talking about OBS and GYN, including the indications that we will use POCUS for, the image acquisition protocols, our techniques, and how to document our findings as clinical officers, as physicians, as midwives. Additionally, I think this is also mostly important. We need to define the roles and responsibilities that the POCUS practitioner will be tasked with or obligated to do. That way, we will have all responsibilities in which all the personnel are accounted for, all those who are involved in POCUS, including their training. Are they going to be supervised or not? Who is going to acquire the image, and who is going to interpret? Is it a combination of one POCUS user or both, or a variety to come to a conclusion on what they have seen? One of the limitations I'll just digress a little. One of the limitations of POCUS is also it is contextualized in that the clinical indication directs POCUS use. We are not supposed to utilize POCUS as a visual tool to give us a diagnosis. Our diagnoses are not going to be image centric. Rather, they're going to be based on the clinical picture of the patient, from which we can determine how then we are going to apply the POCUS tool and get our diagnosis later. So, for example, if a patient comes in with preterm labor, we are going to know that, well, we need to evaluate the cervix. Now, from there, with that knowledge, we will have a plan or standardized protocol, but that says this patient must have a full bladder for us to be able to evaluate the cervix. Then having these clear cut roles and responsibilities will be a very good starting point for hospitals to integrate POCUS for use. Next, additionally, we can implement a comprehensive training program. Well, these are already there. We have a POCUS certification academy, which is run by Inteleos as a overarching management body that provides the basic curriculum or traineeship, in which once you pass all those requirements, then you will be considered certified in POCUS, and you can carry out the responsibilities as a clinician specialized in POCUS to give directions or advise the patient and other clinicians. We can also have competency assessments. This should be done on a regular basis, maybe biannually or quarterly, just depending on how much we think the clinicians or physicians are skilled or require additional training for them to be kept up to par with the ongoing changes or the better education and training on what they really need to know and how they really need to undertake their practice while utilizing POCUS to improve the quality of healthcare for their patients. Mentorship programs can be also a part of that. We can establish quality assurance programs and improvement by doing internal or external audits. Well, that now becomes an administrative element that is going to be requiring an external sonographer or doctor or radiologist to come and see how are you applying the tool. Also, we should remember that as an imaging tool, we have picture archiving software. By that, we mean that all the images which are taken of patients are being archived or stored somewhere. So by doing an internal audit, we will have thousands of images which have been taken, which radiologists or a sonographer can go through and see whether they meet the threshold of what constitutes a good image acquired for diagnosis. Then that
Thank
will...
Thank you, Shadrach.
Thank you.
Thank you. Thank you. Thank you, Shadrach.
Thank you, Shadrach.
I think we are out of time. We have 3 minutes. 3 minutes. And I would like to post one final question to Dr. Joseph Williamson. Dr. Joseph, in 1 minute, what do you think are the impact areas for POCUS? I'm asking this because you started by introducing this, but I want you to just put it out there for people to understand. What are the impact areas for POCUS?
I love the way you only gave me 1 minute to answer a question that I could probably speak for a year on. So I'll do it in try to do it in 1 minute. For Africa, especially for Africa. So I see the impact areas being one, primary care. Primary care needs POCUS to be able to actually do all the things that we spoke about, bring down costs, increase patient care, increase access to patient affordable care, okay? OBGYN is at the top of the list of that. Number 2, rural and resource limited settings. If we have patients and people in areas that cannot access hospitals and cannot access a treatment place like Dr. Nundy or our sonographer or myself, then POCUS becomes imperative to have in these areas. So I think that these 2 areas, both rural settings and primary care settings, are where we need to see the POCUS the most. We can then go on to talk about critical care, cardiology, vascular medicine, HIV, but we need to actually attach those still to the rural areas and primary care. So I'll stop with that, Moses. Thank you.
Thank you very much. Guys, we are out of time. You can look at the poster and see the contacts that we have provided. There's also some contacts in the comment section. You can continue sending in your questions, your requests for quotations, or any other clarifications that you might require. We will be happy to actually answer you and get back to you where it is important for us to do that. Otherwise, thank you so much, Dr. Joseph Williams. Thank you so much, everybody who joined. Remember that at Nectar Gynecology and Fertility Center, we are committed to advancing maternal healthcare through innovative solutions. And that's why we are hosting this webinar on POCUS. As part of this initiative, we will hold an intensive 3-day POCUS training from May 28th to 30th, where participants will gain hands-on experience and become POCUS certified. Each afternoon will feature practical sessions designed to equip healthcare professionals with the skills to implement POCUS effectively in their practice. So join us in this transformative experience and learn from the expertise of Dr. Nondi and Dr. Joseph, who will be bringing a wealth of knowledge and real-world experience in obstetrics ultrasound. Stay tuned for details on registration and charges, which will be shared across all Nectar social pages that are present. Don't miss this opportunity to be at the forefront of revolutionizing maternal healthcare. Thank you so much, guys, for attending. I know that this is a discussion that can go on and on and on and on, because this is a very interesting perspective and an interesting idea that is actually out here. Otherwise, thank you so much for joining, and I would like to end it there unless there is any burning question.
Thank you, everyone.
Thank you, everyone, for joining. Kindly keep your questions coming, your comments coming. Thank you for joining, and good night.
Good night.
Thank you.
Thanks and good evening. Ramadan Mubarak.
Ramadan Mubarak.
Good night.